and welcome everybody. Thank you so much for joining us for this session. We know that we're the last session of the day, but I don't think we'll disappoint. And as Tracy said, we're really talking about a very important topic, which is capital planning. So I'm Donna Deckard. I'm the Director of Strategic Projects at the Center for Health Design. And I'm joined by three members of our Built Environment Network, or BEN. And I'll talk a little bit more about what BEN is in just a minute. But Kevin Vaz from Corewell is the Senior Vice President for Facilities and Support Services there. Molly Ironmonger is the System Director for Planning and Preconstruction and Construction at Secours Mercy Health. And Clayton Mitchell, or Mitch, is the Senior VP of Real Estate and Facilities and the Chief System Design Officer at Yale New Haven Health. So really delighted to be here with these people. And before we get into the actual meat of the presentation, I wanted to find out how many people know about the Center for Health Design. Well, there's a few hands out there, so that's great. I wanted to take a minute just to tell you who we are. We're excited about this partnership that we have with Interface and not Interface.
Influence.
HealthSpaces. So you may not know the name, but you may know some of the things that we do. Perhaps you've heard about the Pebble Project. I see some nods. We also were the educational partner for Healthcare Design, or HCD, the conference. And we're now doing that with ASHE PDC. We also, I manage the EDAC program, or Evidence-Based Design Accreditation and Certification. And we also were the creators of the HER Journal. So hopefully you know some of those things, and we'd love to have you get to know more about the center. Our vision is to really advocate people to build environments that optimize health. And we really hope that they do that through informed design or using evidence-based design. And the way in which we do our work, we have really three pillars: research, education, and community. And we want to try to have more people involved in the work of the center. So if you have questions, grab us tonight. Our CEO is here, Deborah Levin, and our VP of Research, Ellen Taylor. So please feel free to talk to any of us this evening or tomorrow. All right, let's dive into the content for tonight. And I want to talk a bit about the Built Environment Network, because I think it's a really great example of what we're talking about when we say community. As Tracy said earlier, it's a group of senior level executives from health systems all around the country, along with several industry partners. And the group is meant to come together, really have a place where they can have a very intimate conversation with their colleagues. They can share and talk about ideas or topics that are of interest to them. And it's one of the best things that I get to do in my job at the center. We have three other networks, so if you're interested in learning more about that, we have a pediatric network, one for behavioral health, and one for aging. So these are the members of the network, and as you can see, we have, I would say, about 30 people now, 20 health systems, and then a variety of industry partners. And we really don't want to get too much bigger. The whole idea is that when we come together, that it's an opportunity for them to really engage with each other and not have it be like a conference, but a real time in which they can spend time together. This is a picture from our last meeting, which was in February at Jacksonville, hosted by Baptist Health. And we had a great time there. We were able to tour their cancer center when we were there. All right, let's really talk about capital planning. Each year, the BEN members have an opportunity to really pick a topic that they're really interested in and want to work on. and they chose to really focus on capital planning this year. And one of the things that they did in the meetings that we had about this topic is they created this process that you see up on the screen now. And we're not going to go through every step of the process, but we are going to highlight 3 of them: strategy, organization, and governance and approval. So we'll dive deeper into those 3 areas. The work is also designed around best practices, and so you'll hear that from them today as they talk about each one of those areas and what they're doing in their health system to really execute these different processes. So, Kevin, I'm going to have you talk about definitions and
Sure.
tell them about what we're doing.
Sure. So I do want to give one plug. The Ben Network really is an awesome group of member only, and it does allow us to have, Donna's words, more intimate conversations. So as we talk about a few of these key steps and what best practices are, it really is because we have this intimate environment where we're comfortable sharing with each other and maybe sharing a little bit more than we would at one of our larger conferences. Also, one of the reasons HealthSpaces is such a neat venue. So why is it so important to align capital to your strategy in healthcare for success? It's interesting, if I go back to the 8 o'clock panel this morning, a lot of the themes were aligned to this. Like, we're all working with the same set of problems. So how do we actually align strategy and capital planning so that our facilities can be successful? So what is really doing the work, allocating, evaluating, and managing the funds for not only our projects, investments, buildings, infrastructure, but also durable goods and IT. The why is probably the important part of this slide. Maybe a different way of saying it is, how well is your health system set up to manage their capital to react to market forces? Right? We know where there's a lot of changes that's going to come out of the federal government. Hopefully in June, we'll have all of our anticipation cleared up with actually what the bill will be. And how well is your portfolio, your facilities portfolio, aligned to strategy to react to that? That's the value of doing this work. How well can you manage risks, whether that's business continuity or how well can you manage regulatory risks that could come from that? How well can you allocate resources because you've aligned strategy and capital planning through facility operations? In my organization, we actually talk about that the dollars are not the constraint. It's actually the shared resources of our EPMO, our digital services, all of those teams that have to touch projects when we're building very, very large new towers. Or how do we just plan for long-term success? And I would argue that aligning strategy and capital planning in healthcare is one of the ways that we do this. And then the how, really, it takes operations, it takes facilities, it takes your finance team, and it takes your strategy team, and they all need to get on the same page with some framework to be successful. So I'll hand it over to Mitch to talk a little bit about strategy.
Yeah, thanks, Kevin. And I'm also not just part of Ben, I'm on the advisory board for the Center for Health. And so just really, especially during the Black Swan event of COVID, it was really great to just have that group to sort of kibitz about in terms of, what different systems we're doing, were we aligned, were we not aligned. And I think the other thing that we got to do is really sort of drive the industry's response, particularly as it deals with ASRA, air exchanges, and things of that sort in a collective. So Kevin talked about this gap. Well, he didn't talk about the gap, but I'm gonna point out a gap between the strategy and the planning. This is a slide that's really sort of depict, not the process for filling that gap, but a construct for how we might look like that. We start with an enterprise vision, concept development, and that's usually done devoid of us. That's done in the C-suite. That's done, and for a lot of systems, people are sort of talking about capital projects before real estate even gets engaged. I'm a proponent that we need to swim upstream and influence more of the front end. So that enterprise vision and concept development, that does need to be informed by some of the vision that you have for your real estate portfolio. the organization and system strategy is usually developed by your EVP for strategy or your strategy folks. And so if you think about a little bit of a firewall there, they've developed sort of an initiative of what they want to do, and oftentimes they start with the solution. I need a tower. I need a new facility. And so that's really sort of, in my mind, coming up with the solution before you put the rigor behind it. So where you look at strategic initiatives planning, I think that's the Fulda Gap. Any of you World War II veterans know that the Fulda Gap was between Germany and Russia. So think about the strategy and think about the planning necessary to execute that strategy. The things that you see underlined are what I've seen in the systems I've worked for and the systems I've consulted for with as areas of opportunity. And so part of my role as Chief Systems Design Officer is around just how do I fill that gap for Yale New Haven Hospital, so that facilities master planning, site-specific projects, that's table stakes for us in this real estate things. Once we've got great signals and there's rigor behind them and there's a solid business case, we can execute. Execution is not the issue. It's the front end, not only decisions, but the indecisions that sort of handicap us. So I think Kevin's got some thoughts and ideas on how he's done that with Corewell.
So Mitch explained the framework. It's one framework, but it starts with a vision, right? That goes to a strategy, that goes to master facility planning and projects. So I thought it would be really valuable to this audience to talk about Corewell Health, because Corewell Health is a case study of walking through that whole vision. So Corewell Health, if you don't know, is a 3-year-old health system that is based all in the Lower Peninsula of Michigan. We have 21 hospitals. We're the largest employer in the state. We have the highest market share of licensed beds in the state, and it's a merger that formed from Legacy Beaumont and Legacy Spectrum Health. So right there, we had to have a vision, or our senior leaders had to have a vision, and you see on the left-hand side of this slide our mission, vision, and values that was announced in the announcement of Corewell Health coming together. And then we started thinking about our areas of focus or our company direction. And those are the 5 bubbles that go around the middle of this slide: strengthening culture, simplify, transform, prove, and expand. But then as we as a facilities team said, how do we bring that to life? We created facility imperatives. So when we think about strengthening culture, we want our environments where our team members are proud to work and provide care. Right? When we think about simplify, we want convenient locations and we want them to be easily accessed, right? Wayfinding in different aspects of the environment that way. When we think about transform, we want long-term vitality, efficiency, and optimization to those. Think about prove, that gets into the fact that Corewell Health is an integrated health system, so we both have care and coverage, so we want to think about how we use our built environment to prove out some of those value-based models. And we think about expand, we think about how we need to grow in the competitive marketplace, inpatient and outpatient. And if you go to the next slide, let me step back 1 second before I talk about this slide. When we became Corewell Health, our senior leaders not only decided on our mission, vision, and values, but they decided whether we were going to be an operating system or we were going to be a holding company. And they answered that question that we were going to be an operating system. And some of the artifacts that say we are an operating system is that we have all approximately 6,000 beds on the same instance of Epic at this point. And we had that about 2 years into our journey. We took 3 instances of Epic and moved them all onto one. So that is one artifact of us being an operating system. We also have the common Workday platform across our whole system. And what I'm most proud of is we took 2 disparate master facility plans and we created one enterprise strategic facility plan for Corewell Health. So then we took those 5 strategy areas and we took those facility imperatives and we said anything that's going to come out of or be a recommendation to the board out of our system master facility plan is going to be tied to one of these facility principles. And those principles are appropriate facility scope and size, facility improvement, modernization, gross, stable ambulatory footprint, and localized low acuity care. And this all goes back to Mitch's framework of starting with a vision to going into a strategy and then master facility plan. This is what we did at Corewell Health, something that I'm very, very proud that our senior leaders were willing to go through. And how this comes to life is we have a 60-person in-house construction team that has approximately $16 million that they can play with based on facility condition assessment to do refreshes of the 6 sides of a room. And it has great effect on facility improvement and modernization. We get a significant amount of team member engagement scores from nursing that they see us invest into the built environment in that way. When we think about simplify, we're thinking about, we learned through our master facility planning that we have a lot of people traveling past one of our regional hospitals to go to a flagship hospital. So how do we put improvement into some of those regional hospitals so that we can repatriate patients back to those hospitals so that we don't have to keep growing our flagship hospitals? We want to grow them where it makes sense, but not grow them past what we need to. When we think about transform, we looked at the number of ICU rooms and the number of double occupancy rooms. And I'll just use ICU rooms. We have 11% in one of our regions of ICU rooms when really the data says we should have 22 to 25%. So how do we think about that through improvements and modernization? And then when we think about expand, that gets into our integrated care campus footprint. It gets into our ambulatory surgery center joint venture footprint. So I wanted to talk a little bit about how we created, our senior leadership team created a vision, created Corewell Health, created a strategy, and how in facilities we've now moved that into an enterprise strategic facility plan that has governance, and it has intake and approval and evaluation and all of those aspects that Ben has evaluated in the best practices for capital planning.
Great. Molly or Mitch, you want to add anything to that whole concept of strategy and being linked to the capital plan?
I think my role exists because of that, because we really realized that we had disparate directors working in the markets. We have 10 markets, approximately 46 hospitals wholly owned, 50 if you count some of our joint ventures. And so I sort of sit in between everywhere and nowhere at the same time to make sure that we're in line with strategy and when we're in line with facilities planning and everything else to make sure that all of those work streams are swimming together. And so we exist because of that. And I just want half of his people because we have 23 people for all of our hospitals. So.
And what I would say, Donna, we've had this conversation ongoing for a bit, from my Jefferson time through my advisory services. Just really, how do we get a stronger voice in the C-suite and to really sort of articulate this? So I think what part of the construct of developing this chief systems design officer is Yale New Haven saying, you know what, we believe you. So we do think we need to be herded or sort of have a certain structure to go from strategy to execution, because the business case, is probably not as strong as it can be in some cases, the rigor and things of that sort. So we're 4 months into that journey right now, but we have a really good execution platform. If we get the signals going into that, we create that vision for where the system's going. And oh, by the way, we're being allowed and enabled and invited to the table to set that course. Then I think in short order we're going to be a high performing health system like Corewell.
All right. Well, let's move on and let's talk about what gets funded. One of the things that the Ben Group talked a lot about was that everything is important. And I heard that this morning, that it's not just the strategic projects that get funded, but infrastructure is important. And so, Mitch, do you want to talk about what the Ben Group did to try to prevent that? I think the other thing they said, it's also not the loudest voice in the room that gets their project funded too. Yeah. So what do we do to try to prevent that?
Yeah, I think the group that kicked this all off this morning sort of talked about this, and it's really about what is the operating framework that we use to, what I would say, balance the investments across the portfolio. And so a lot of that is about the data. What data, what systems do we have that help enable that and help sort of enable the prioritization of our funding. Part of it is creating the buckets, right? But I think the other part is really just, as I'm an industrial engineer, and I think that modeling and simulation are two things that are not as fervently used in this space. And so modeling financial profiles of how we can balance growth and expansion, for example, against capital maintenance, against modernization, which very few people are really looking at, against the day-to-day sort of emergencies that are popping up. So I believe that if you can put a framework in place and from a capital program standpoint, execute to 85% of your program year over year, you're going to be in a good place. Use that 15% to sort of deal with the one-offs that are going to come up every year. And you do basically sort of a balanced look across the buckets that you're funding from a risk-based standpoint, because we think we're facilities managers, we're really risk managers now. We're managing that risk until systems can get to a place where they're creating the margin to really reinvest. It's up to us to really sort of help them balance these buckets going forward, to keep not only keep things moving forward, but I think you can also begin to future-proof and modernize, as we've talked about all during the day.
What about infrastructure, Molly, Kevin? How do you allow money for that and it doesn't all go to the big strategy projects?
Yeah, I would say within our Bon Secours Mercy Health system, we are pretty rigid within those buckets. We're in the fiscal plan for the future year, each bucket is assigned, and you can't go steal money from one to support the other. There is some, for example, if we know a routine bucket right there is going to happen this year where we're going to refresh rooms, but I know in 2 years we're targeting that same floor to be replaced with VAVs. We can do some horse trading and try to consolidate so we can be efficient with our monies. So we can do those two projects concurrently, but I can't all of a sudden start using my infrastructure dollars to repaint. Like, it has a purpose, it has a plan, and same with like our information technologies, and we get pretty rigid about them, and then each one of ours have their own, when we get to it, like prioritization and governance structure around each funding source, so that you can't go steal one pot. And to the point this morning of everyone wants to go spending money on an MRI, and infrastructure is never going to compete with an MRI that makes money.
Right, right.
They are handlers only. People care about them when they break.
Yeah.
And maybe one thought that I bring is that I think this is a really interesting discussion, especially around the pace of merger and acquisition, so that a lot of times we as facility leaders or real estate leaders are left with, we've come together with two systems, and are we really going to take money from one system, to think at more of a strategic corporate level? One thing that Corewell did is we put our enterprise strategic facility plan at a corporate level. We put our facility infrastructure at a corporate level. So we took those regional buckets of infrastructure and said, we're going to move it up here, and it's going to be governed here. And I have a strong bias that is a better way to do that, because often the regional voice is the louder voice and not using as much data to govern the decisions.
Yeah, and I Jordan hit this point in his discussion, when he talked about real estate rationalization. For systems that have grown through mergers and acquisition, the sooner you get to rationalization, the sooner you take pressure off of this, right? Because these buckets are crafted around, in a lot of cases, a holding company mentality, and you're trying to fund everything. The reality of it is you just have to start to rationalize your hospital infrastructure, rationalize your acute front infrastructure, get that down to the smallest footprint necessary to deliver your mission, so then you create capital to do some of the other things that you need. And I think that's where a lot of systems struggle in a major way.
Okay. Molly, we just talked about mergers and acquisitions. So, in the past days, sometimes you just had one or two hospitals and you had to figure out what capital allocation to give them. But now with the M&A, we're talking about multiple systems that are coming together. In the case of Bon Secours, you're talking not only about multiple systems, but facilities in several states. So the complexity of capital planning is getting harder and harder. So what do you guys do? What does Bon Secours do to try to address, the different needs in the different markets?
Yeah, lovely slide. So we talked a lot about the ideation. So we have 10 markets, as I said, and you'll find that all of them will be loud and be advocating for their projects, even at a hospital level. So I'll do Cincinnati. Cincinnati, we have 6 hospitals. Something that could be really important to the hospital at Claremont might not be what's really important for the market, knowing what the market needs to go through. So we ask each market to come through and synthesize all that ideation, even to those BHAG projects of new towers or whatnot. And they need to bring forward what is their best projects. Our team works really collaboratively. We get a seat at the table. If you watched the Tony Awards, we like to be in the room where it happens. Design and construction, if we aren't there, the projects usually fail. But we help them rationalize what those projects could be and would be, and we help the markets go through some sort of qualitative scoring. Like, you need to be very open with why projects are moving forward and why projects are not moving forward in a way that transcends the human that's making that decision, because those people change over. And then those ideas and decisions get bubbled up to the system level. In all those buckets from the last slide, we have a process where it gets bubbled up into a system bucket to then prioritize. What could be right for Toledo might not be right for the market, in the same way that what right in Claremont might not be right in Cincinnati. So then we equalize those projects and look from that system perspective of what is the system going to be wanting to do. Infrastructure could be really bad in Youngstown, but we need to address essential utility plant in Paducah that the nun goes out each morning and blesses the switch gear because it's from the 1950s, and I am not kidding. So through all of that, then we have to then rationalize those projects and what funding is available. I said we were pretty rigid upon our projects. There are more projects out there than there is funding, and there will always be more projects that are out there. So you have to figure out where that line is snapped in the projects. But we want to have some flexibility against that line, because if we, for whatever, have savings, we have a rigid process in contingency harvesting that we can deploy more capital that year. We want to be able to know where that project line is, or like I said before, if a routine project needs that money, like a routine project's going to refresh and it makes sense that we synthesize into that project and have them concurrently, so we can have the general condition savings and all those costs. So that's sort of where we find the line. It also lets us, where I say we are in the rooms where it happens, it lets us be the ears, especially me in my role sitting with strategy. It helps us make sure we are communicating across those bucket lines. If we're, for example, planning a major infrastructure upgrade in one of our facilities, but we know strategy is intending on planning the service lines that we deliver there, we need to make sure we don't over or under build that infrastructure for replacement. So we're not doing just like for like. It also lets us study some of sustainability and things that we aren't being first cost conscious, we're being long-term conscious. And then in each of these levels, if we want to go to the next slide, there is some sort of governance that needs to be evaluated and created. Infrastructure, there is a group that's together. It has something to do with age of equipment, operational equipment, our CMS data. On our newer facilities, we have electric submetering, so we can tell when projects are going to go bad. And so then each equipment gets ranked at the hospital level, then market level, and then system level, and then the projects all lists, and then the budget sort of tells us what projects are happening and what projects aren't. Sometimes if we are really concerned about a project lower, then that's actually how we've been able to rationalize our infrastructure budget. From when the program started in 2019, it was $30 million a year, and we spend somewhere between $65 and $80 million, and we're going to have 110 next year, because we're looking at our technology, our deferred maintenance, and we won't be able to continue providing care if we don't make this investment based on all of this data and rationalization. For our big strategic projects, we have to consider mission as well as money. No margin, no mission, but we also, in a lot of being a Catholic not-for-profit, we're in facilities that will never make money. That's not what they're there for. Their job is to provide care for those underserved and dying. And I should know our mission better, but it is blanking my mind. Here's an example of one very specific matrix that we created within our ambulatory bucket for freestanding EDs. Sometimes we have very specific programs on a specific type. And as we're looking across our entire footprint, how do we rationalize an FSED from Toledo versus one in Richmond versus one in Greenville? And so we made up this rubric that we went through and scored. Every market was able to put in all their ideas of where we should put FSCDs. And then we went through and synthesized the top list. We're trying to deploy, we will deploy 10 FSCDs in the span of 5 years or less. And it could be 12 FSCDs in 4 years. But so we know which ones in which order, which ones then, if for whatever reason we can't get to, we just are right there with the next one and ready to roll. So that helps us prioritize and sort of always have a project in the hopper. Think of like a sales pipeline. We always sort of know what our next leads are, and we're sort of working them through that sales funnel.
Great. Kevin and Mitch, do you guys want to talk about a governance and approval process that you've tried to put in place? Especially you, Kevin, you said you've got running things at a centralized level.
Well, so in our 5-year capital program, every year we have a multi-year enterprise strategic facility line item. So when we do our budgeting every year, there is dedicated dollars, and it's usually north of 50% of our total capital program that goes to the ESFP. And the way that we used to do that is that corporate would be given some dollars based on need, and corporate really is managed by the CFO, and then all of the care delivery regions would get dollars by our COO. And once the CFO said, care delivery gets X, the COO then says care delivery region A gets this, B gets this, and C gets that. And then they rank and stacked based on different data. But we never knew if region A's 3rd project was better than region C's 8th project. So what we are doing now is we are actually creating common data points that we're evaluating. We're not changing the structure necessarily, because there's a lot of different dynamics to changing the structure from a change management standpoint. But we are behind the scenes creating a similar scoring methodology so that we can help inform the COO exactly that scenario. So it's a journey is the way that I would say it. And even though we have some methodologies that are very helpful, we continually iterate and say, should we do it this way next year?
Okay.
Yeah, and I think, I mean, we're permutations of those 3 main capital committees: a strategic medical equipment committee, a strategic capital oversight committee, and an executive business project council. Those 3 committees sort of suss all of our capital requirements into various buckets. And so I think particularly on a strategic capital oversight committee, part of what we're going to be doing is like restructuring and bringing a little bit more rigor in sort of as Secours and Corewell have sort of articulated, so we can develop what I would call sort of an authoritative capital program that stays fairly consistent year over year, right? We need to remove a lot of the variability year over year. We need to have greater rigor. If a shiny fish comes through, does that really align with our strategy, or is that something that actually takes us off point? And you know, our new president has really brought an immense amount of structure and rigor to this point, and I think they're looking for us in real estate and facilities to help sort of refine that going forward. And it's in that middle gap, that middle line of activities that I talked to on the previous slide.
So do you want to, wrap up with why this was so important for the Ben Group and the long-term view?
So just real quickly, because I want to get to some questions, but look at these 2 models and determine which model is predominant in your system. Is the one on the left where you're making that initial capital investment, and then you just burn that facility till it's done, I've been with 4 major systems, and that's pretty much the consistent model in each of those systems. I think on the right, though, is that 100-year plan where you have to figure out what is that sustainment model that we need to sort of invest with over time to sustain that that building at its level. I remember being at Kaiser Permanente. Bernard Tyson took a trip to Europe, and he was amazed that you had these hospitals and buildings that were 200, 300, 400 years old, right? Well, they were there probably because they're more on that right than they are on the left, and so as we think about how we go forward, right? Maybe we can't. It was talked about this morning. Maybe we can't afford 15% FCI. Maybe it's 25% FCI, which means we got to put a little bit more risk into the management of our facilities. We have to be more effective in arguing for better sustainment of the buildings we're building, like right now. If we don't do that, we're just in this perpetual state of chaos. And with the headwinds that we've got coming forward, and you know, we heard Jefferson talk about putting $90 million aside, and others talking about, you know, bucketing funds. We have to do that to better manage that out-year risk.
We want to say thanks again for coming and being a part of this. If you want to know more about the Built Environment Network, please talk to me or any one of our members. And we do want to take some questions.
Questions?
I want to thank the panelists because I think you've hit on everything, but my question is specific for you, Molly. You had a slide where you discuss ideation. And so how do you deal with a ton of ideas? Because in our system, we have a lot of people that are like, oh, I'm dreaming of this. But in order for me to present, I need you to do a lot of the back work. And it takes a lot of time off of the staff just to do a lot of the homework to even present for ideas that don't even get to the starting line. So how do you help mitigate and take out a lot of the stress that usually comes to facilities planning, design, and construction to get it precise to the point where it's more of a science versus a strain?
Yeah, great question. So I would say, one, our ideation, again, it's part of why I exist. If somebody gives me something, my job first is to say how many O's there are, and there's not enough of the people I work with every day to know that I'm saying how big this is. And so we work through, like I said, it was a pretty clean process. It's multiple iteratives. We're like, all right, this project is $1 million, and they'll say, or we'll do big ones. Like somebody will give us an idea, and I will quickly, using our benchmark data, we keep cost database of everything that we spend, and then I can go tell you within 10% what this project's going to be based on some historical cost data. And then we say, okay, based on what you say you want to do, that'll cost $50 million. And they're like, oh, that's not what I meant. I have $10 million to spend. And then we'll come back and me or the regional director will be, okay, to do a $10 million project, it'll look more like this. Is this palatable? You know, we're not going to build a brand new ground up MOB. We're going to go into lease space. It's going to be an older building, or we're going to do this kind of thing. We're going to have to buy some of this stuff reused. Is that palatable? And this is really quick and dirty. If you've ever looked at like lean delivery for software, we go quick and we go fast with okay information. And then we get to the end. Pretty much it gets to a rubber stamp because we've been coming back so often, and we know that for big projects, we have a 2-bite process for our official capital approval. The first one is, we think the project's going to be about this big. It's off conceptual drawings or a narrative, but we need this amount of money to tell you how much it's going to be, and we get that approval. We'll start building a big room, usually because those are big jobs, and then we'll get them moved forward. So it's really rapid iteration, using historical concepts and making sure people are okay with those WAGs to get started, and then we can get to those ideas of what they really mean faster by throwing data back at them quickly.
Yeah, I would say that at least the first 2 blocks on the slide that I presented are about ideation, getting to some sense of a preliminary business case of what that idea is, to see if it's something that is aligned with your strategy, is it aligned with some other objective, some other emerging imperative, and then to balance that or evaluate that against other ideas you got in a structured format. I think a lot of challenges that systems have is maybe that strategy isn't as well developed as people think. So a lot of the ideation is about things that obviously don't align with the strategy. I think for Yale New Haven, we want to just be able to just say, hey, look, those may be good ideas, not aligned with our strategy. I was really, sort of impressed with our CEO. There was a potential merger that could have occurred. It was maybe more of an acquisition. And he basically said, you know what? That's going to take us off point for our strategy. We need to double down on that, double down on integration. So that might seem like a good idea. Maybe a lot of people in the state want us to do it, but we're gonna stay the course on our plan.
Hi, thank you. Keely John with Emory Healthcare. When you talk about looking at these in a systematic way, and I know everybody's structured differently, but who are those decision makers that then are evaluating those? Is it your teams? Is it the COO plus the CFO? And then is all of this within your capital budget season? They're all submitted at the same time with a capital call, or do you have off cycle requests and are those handled the same way?
So I can do specifically our strategic projects, for example. We know approximately how much we're going to spend per year in that bucket, but it is a rolling one. But we sort of know what's out there because we've been doing rapid iterations multiple years in advance. Our capital committee for those big projects is comprised of our chief strategy officer, we have multiple chief strategy officers, so all three of them. Our chief mission officer, so Father Cardone, our chief real estate officer, who is my boss's boss, our CFO of core markets, our chief medical officer, and our chief operating officer are the ones that all sign off. So it's a cross-sectional team, and they all sort of sign off. I would say for our infrastructure team, it's a cross-section of we pull together a team that's built each year. Again, the program is approved on a yearly basis, but project specifics roll through. And so projects can fall on and off based on their scoring because we sort of are always looking at their scoring, know kind of what they do.
So at Corewell, the strategic bucket I've said is called Enterprise Strategic Facility Plan. The executive sponsor that owns that whole plan is our CFO. He partners heavily with our COO of the organization, and then we have 3 care delivery regions, and those subcommittees are made up of the regional president, the regional COO, and the regional CMO. We keep it very, very tight. And then there is facilitators like facilities and real estate and strategy that are assigned to each one of those buckets. So we know what our top priorities are, but with things like site neutrality potentially coming, we're trying to figure out how we can pivot quicker, which goes to the why of why this is so important. And I think you're right. We all have different structures, but if we can, within our structures, create some clarity of like what the best practices are, I think we'll be further ahead.
Yeah, and I think for us, it's a work in progress, but we're developing a working group feeder into our strategic capital oversight committee that will do all of that rigor, a lot of the things that you guys are talking about in terms of facilities, facilitating all of the activities that need to be done to sort of execute the capital program. If you look at that slide that I had, think back to it, it didn't have any design. Design was out here. I think in the best case scenarios, you should do as much of that work in advance as possible before you bring an architect on board. I'd expect to see tomatoes coming in from the architects in the room. But I think what happens is we go to the design community before we've fully baked an idea or a concept. And when we're trying to do some of that ideation, some of that planning, some of that programming during design, heaven forbid during construction, heaven forbid we're revisiting the business cases during construction or design, those projects are destined not to beat their business objectives. So my argument is let's put some investment in the front end planning, get really good rigor up front so we know succinctly and we have a really good ideas if this is a good project or if this is a project on a very tight business case or if this is a loser but we needed to do it for some other reason. We need to know those up front. I think we'll have better execution, better alignment between what we execute from capital and what our business objectives in the end.
Any more questions?
Okay, last question.
Hi, Katie Smith from Children's Mercy Hospital in Kansas City. Curious how you guys integrate your IT department into this planning cycle. I've heard you say a lot about strategy and finance, but I haven't heard a lot of IT in these core teams that you're talking about.
Our IT is always late, and they're not here, so they can't throw eggs at me. Because they're always late, I just have been tracking their costs recently, and so I can tell within pretty good because I look in the past costs, and then they'll come out with their estimates, and I'll be within 5%. So what we're also seeing though is a rapid escalation of our IT costs, and what we're finding more is in our renovations, we have a lot of infrastructure to deal with. But yeah, no, ours is always late, and we are dragging them across the finish line half the time. A big fight for us right now is getting IT project managers, and we will be like days from opening and still don't have an IT project manager, and we will have done it all, and then they're mad at us that we kept going. I bet everybody else.
We have a pretty solid partnership with IT. Particularly in light of the fact that the next biggest heavy hit on a project outside of the actual construction is IT. But I think, like Molly says, a lot of times they're lagging in terms of validating their costs. So
we also have taken over everything that's not a computer and software. So
Yeah.
we do like nurse call, we do telemetry, we do like design, construction, and medical equipment planning, which we manage all of that. We do everything that exists in the built environment. So they're just bringing in computers and software, which helps us that they can come in later because of all of the delays. We just started.
I do think they both IT and medical equipment do have some challenges, because on the medical equipment side, and the two systems I've been in, medical equipment is really closely tied to IT. They're waiting for the bitter end to be able to sort of buy some of the equipment and things of that sort. So that can be problematic if they don't have solid costing and things of that sort. But it's just something we just have to maintain that close tie with them and that close partnership with them.
All right. Thank you. Thank you so much for the discussion. Great topics.